Welcome to today's special Grand Round. This is the series that focus on important studies from the American College of Cardiology annual scientific session. And there are going to be 5 different studies that will be presented by our very talented fellows who were in attendance during the meeting. What I really enjoyed as part of the meeting, in addition to getting to know the work that each one of them is doing, was also a highlight to showcase some of the important contributions that happened from the division. So these are some of the compilations of pictures I thought I'll just share with you. So one of the things that we celebrated is the success of our fellowship program. We had a strong presence and we had representation from New Jersey. So our fellows went into the semifinals. So you can see the picture from there. We had significant presence in the poster presentations. And also there was enthusiasm in networking and socialization activities throughout the conference. We had also a remarkable conference, and for me, it was a very personable conference in the sense we were awarded not only for our personal achievements, but also importantly for mentorship. And seen here are pictures from the editors of important journals. So you can see Dr. Fulster from Journal of American College of Cardiology, Dr. Batarseh from Journal of American Society of Echocardiography. And here you will see some well-known figures, Mamas and Mamas, and Tom Nealon's, and this was during the Times, Becky Han, so on and so forth. So multiple people who showed great interest in the work that was being done. And there is already a sense of an academic work that is evolving in Rutgers Robert Wood Johnson Medical School that was very well represented by the group that came from here. But most importantly was the time to be able to spend with our young trainees, our future, and to be able to getting to know each other and bonding with them and making them feel secure as we try to transform the culture of how we train them. I want to just acknowledge the enormous work and the enthusiasm with which they have been helping with the clinical services. And as we go through this translational period, and as the division is slowly evolving, we're going to ensure that we will enter into a future era where scholarship, clinical work, and the culture of maintaining an academic environment will be upheld. So with that note, it's my pleasure now to be able to go into the invitations to bring forth our group. First and foremost coming in the lineup is Dr. Christopher Wong. Dr. Wong came to us from Northwell Health, where he did his residency in internal medicine, his first year in cardiology fellowship. And he has enormous interest in research, particularly on health disparities, and he has already shown a great interest in spearheading some of the research work. So I'm going to invite Chris to present one of the key trials and take it on from there. Chris? If you unmute yourself and you're muted. Chris, you're muted. All right.
Sorry about that. Okay. Can you see my slides?
Yes, we can.
Okay. Great. Yeah. Yeah, I'm good. Thanks. Thank everyone for giving me the chance to speak at today's grand rounds. Today, I'm going to summarize the final 5-year results from the co-op trial. The co-op trial is a trial that investigated the efficacy of edge-to-edge repair for secondary MR in dilated cardiomyopathy. They started enrolling in 2012 and finished in 2017. Included patients with both ischemic and non-ischemic cardiomyopathy with reduced ejection fractions and MR that was either moderate to severe or severe with symptoms. Now, importantly, they maximized GDMT prior to randomization. This included CRT. This will become important later. And they excluded patients with dilated left ventricular and diastolic dimensions greater than 7 centimeters, severe pulmonary hypertension, moderate or severe RV failure. And at the end of all of this, they included 312 and 302 subjects to their control and intervention arm, respectively. And we've been, as a society, following the results of this trial keenly. Perhaps most importantly were their 2-year outcomes that showed a dramatic improvement in these patients' natural course. In 2019, they showed the results in tandem with the MITRA-FR study. From these 302 patients who received a mitral clip, 312 controls, they demonstrated a annualized risk of hospitalization of 35.8%, down from 67.9% for hospitalizations. Death decreased from 46.1% in the intervention group down to 29.1%. But at the same time, MITRA-FR was a negative study, similarly administering mitral clips to patients with secondary MR. Their combined endpoint of death or hospitalization was null. At that time, going through kind of the current debate, this discrepancy has been attributed to a lot of things, but perhaps most prominently, the idea of disproportionate MR for dilated LVs. In the MITRA-FR trial, patients were found to have, on average, more dilated chambers and less severe MR, whereas the converse was true in the co-op trial. What more, the co-op trial fully up-titrated GDMT prior to randomization, suggesting that perhaps there was some degree of MR that was proportional to the degree of LV dilation in MITRA-FR, and that could have been treated with medications, thus leading to perhaps this negative result. This is where we for the most part, left the co-op trial until now, where we now get to see their final 5-year results. So going straight into their results, we see that these impressive outcomes still persisted. There is a decrease in first hospitalization, 83% in the control group at the end of 5 years, 61% in the intervention group, and death from any cause is also remains reduced, 67.2% in the control group versus 57% in the intervention group. I want to note 2 important things on this slide, though. First, for hospitalization, it seems like on inspection, we can appreciate that the gap stops widening at about 36 months. So too for death at 24 months. What more, the second thing that I think is important here is that even in the best case scenario with GDMT and intervention with MitraClip, this is a very sick patient population with 57% dead at 5 years, suggesting that there's still much more room to grow. These were the primary outcomes from the 5-year follow-up of the co-op trial. The other thing that's interesting and important that we were interested in following was the 5-year safety profile of this transcutaneous device, and it is safe. There were only 4 device-specific events out of those 302 patients who got the device in the intervention group. or for 293 patients. And that didn't change for that full 5-year period. They were all from the first 30 days. The rest of the safety events come from LVAD and heart transplantation, which are actually predominated the control group, and less so the mitral clip group. We noted previously that the gap did not stop widening after about 2 years for death, 3 years for hospitalization. And they confirmed this on a secondary analysis of Kaplan-Meier curve. It suggests that in this graph, we can see that for death, when you kind of reset the curve and start following after 24 months going further, the curves approximate. And there's no widening of the gap after that point, suggesting that it is within the first 2 years that we really see improvement from for death with the mitral clip. 3 years for hospitalization, though. The other thing that we get to see newly in the 5-year results is that there were patients who crossed over. Per protocol, this was started to be allowed at 24 months, which was not available in the first 2 years of data. 67 of the 312 patients in the control group crossed over, and in a multivariate regression, the crossing over predicted the primary endpoint of death or hospitalization significantly, with a hazard ratio of 0.53, corroborating the results that we've been seeing previously. So the takeaway messages are this. Mitral clip is effective at reducing hospitalization and death within the first 3 and 2 years, respectively. On average, after the end of all of this, 61 versus 83% were hospitalized, 57 versus 67% died. And this gives us a number needed to treat. If you take the 2-year data and the 3-year data, going back to these previous studies, a number needed to treat of 6 within the first 2 years for preventing death, 3 years to prevent within the first 3 years, and you have a number needed to treat of 3 to prevent 1 annualized hospitalization. These are impressive numbers. But this is tempered by the fact that 57% of these patients ended up dead, even after 5 years, even with the intervention, 67% in the control arm. The last point that according to the authors, is the idea of how this relates to the idea of remodeling. There was hope perhaps that by fixing the mitral regurgitation from the LV dilation, we could change the trajectory of how the LV is remodeled, and perhaps garner continuous benefits as the patients progress through their disease course. But this doesn't seem to be the case. It's limited to this 2 and 3 year window, rather than continuing to accrue benefits as patients progress. Those are the main take-home messages, and these are the sources that I use.
Thank you very much, Chris. That was a very succinct presentation of the study. So we will hold on for the Q&A sessions at the very end, so that everyone has an opportunity, and there are no time constraints on presentations. So we'll come back to you, Chris. So thanks for that very succinct presentation.
Thank you.
So if you unshare the slides, and we'll be able to bring in Dr. Alberto Batarseh. Dr. Batarseh completed his internal medicine residency from the George Washington University, and currently is in his 2nd year in cardiology fellowship program. And Alberto is going to present his key trial, and I think that's going to be the Triluminate trial, right?
Yes. Thank you for the introduction. Okay. Can you guys see my screen?
Yes, if you could share. Thank you.
Perfect. Okay, so my presentation's on the Triluminate trial, formerly known as the Transcatheter repair for patients with tricuspid regurgitation, which recently came out in the New England Journal of Medicine and was presented at ACC. So some background, we all know severe tricuspid regurgitation is associated with symptoms including congestive right heart failure, fatigue, edema, which all can cause significant morbidity. Fluid does back up into the liver and kidneys, and patients can develop hepatorenal syndrome, and they also have a high mortality. Current medical therapies largely limited to diuretics. Surgery is only a class 1 indication if patients are undergoing left-sided cardiac surgery as well. And surgical mortality for tricuspid valve repair at 1 year is very high at 8 to 10%. There have been some smaller prior studies that have shown reduction in the tricuspid regurgitation and improvement in symptoms in patients who get transcatheter edge-to-edge repair or TEER of their tricuspid valve. Study design, it was an international randomized controlled trial of the TriClip system, transcatheter tricuspid valve repair system by Abbott, which is a 25 French delivery catheter going in through the femoral vein to place one or more TriClip devices on the tricuspid valve leaflets under ultrasound and fluoroscopic guidance while the patients are under general anesthesia. The picture from the supplemental data, you could see this is the device here, bringing the tricuspid leaflets together to reduce the tricuspid regurgitation, and this is the what the Partho operator controls in order to place this catheter and the TriClip on the valve. The enrollment criteria, so the inclusion criteria were severe TR with at least NYHA class 2 symptoms, class 4B, who were unstable, which is greater than 1 month, goal-directed medical therapy, and deemed to be intermediate or greater surgical risk. So for the inclusion criteria, an independent lab characterized the tricuspid regurgitation as severe, but the local heart team was a team that gave the surgical risk. Exclusion criteria, no other cardiovascular conditions needing surgery, and a PA systolic of greater than 70 millimeters of mercury. So patients were randomized 1-to-1 to TriClip within 14 days of randomization versus just medical therapy. Obviously, this was an unblinded study because no sham procedure was done on the patients in the control arm. They were followed up at 1, 6, and 12 months with symptom assessment, 6-minute walk, quality of life measurement using the Kansas City Cardiomyopathy Questionnaire. So here's the randomization. As you can see, it's pretty well randomized. Similar age, gender percentage, similar comorbidities. Interestingly, the patients who were in the TEER group actually had higher quality of life at baseline than patients in the control group, but otherwise everything else seemed pretty equally and evenly randomized. So the endpoints that they measured, the primary endpoint was a composite hierarchical endpoint, and the parts that it was composed of was 1, death from any cause or requiring tricuspid valve surgery. Secondly, hospitalization for heart failure. And thirdly, improvement in quality of life. Again, it's assessed from the Kansas City Cardiomyopathy Questionnaire. The secondary endpoints were freedom from major adverse events, so death from any cardiovascular causes, new onset renal failure, endocarditis requiring surgery, or non-elective cardiovascular surgery for a TriClip-related event. They also looked at the change in the quality of life questionnaire, the amount of reduction of TR, the percent that went from severe to at least moderate or less at 30-day follow-up, or changes in the 6-minute walk. So the results, so for the primary endpoint, they did meet their goal. So what they did here was calculate a win ratio, which is, so they paired everybody from the control group and the procedure group, and then saw how many in those groups would have a win for the procedure and how many for the control, and then just divided that. So they got 1.48, which didn't cross 1, so statistically significant. And then secondary outcomes, so they saw that the TriClip was safe. They only had 3 adverse events at 30 days. So out of the 172 patients, 2 had renal failure and 1 died. So those were the 3 adverse events. And then they did have a statistically significant increase in their quality of life assessment. 140 out of 161 got improvement in their tricuspid regurgitation to at least moderate, while only 7 did in the control group. And the 6-minute walks, both sides had a decline in their 6-minute walk from baseline at 1 year. but it was increase in the control group, which was not statistically significant. And so looking at the primary endpoint a little bit closer at the different parts that compose it. So freedom from all-cause mortality or tricuspid valve surgery, as you can see here from the Kaplan-Meier curve, didn't really change. So both groups had, pretty low mortality. I know similar in both groups, about 9.4% in the tier group versus 10.6% in the control group. Freedom from first heart failure hospitalization, again, didn't really have separation of the Kaplan-Meier curves. And actually the control group did do better, though not statistically significant. It was 12.1% in the control group versus 14.9% in the tier group. And then how effective was the TriClip? As you can see here, 87% of patients who got TriClip had moderate or less TR when reassessed at 30 days, while almost all of the patients in the control group continued to have severe TR at 95.2%. And then further looking into the results, when they assessed improvement in quality of life according to the severity of the residual tricuspid regurg, so if the patients did have improvement after the TEER procedure, they did have a statistically significant increase in the quality of life questionnaire, while even if they did get the procedure, having residual severe TR didn't have an improvement or, much of an improvement in the quality of life questionnaire. Same here for depending on how the magnitude of reduction of their tricuspid regurgitation. So in both groups, but if they had a significant improvement, they did have statistically significant improvement in the quality of life questionnaire. So what did we learn from this trial? I think importantly that the TriClip system is effective and safe as a transcatheter system to address severe TR, which is the first major trial to show that. The reduction in TR was correlated to an improvement in quality of life. However, there was no improvement in the other primary parts of the primary endpoint, that was mortality or hospitalization, which was, thought to be by the study investigators due to a low incidence of events in both arms. So limitations, well, obviously the study was unblinded, but the only positive endpoint that was met in the primary endpoint was, subjective. So there's always concern that it's because of, the patients not being blinded. Secondly, the study was, supported by industry. Abbott supported the trial because they provided the devices. And then, patients were intensively screened prior to randomization. It's unclear if this is going to be able to be generalized to the general population. Excuse me. So, the patients before being randomized had to, were reviewed by an expert panel to make sure that the TEER system would be effective in reducing the TR. And that's, probably not going to be able to be done at a large scale at a lot of major medical centers that aren't, looking into the study. So that's important. Yeah. So I think that's it. Thank you guys for your time. And I think we'll take questions at the end.
Very nicely summarized, Alberto. Thank you very much for that nice presentation and your editorial commentary on it. So it goes a long way to showcase the value of bringing further science into discussion. Now we're going to move ahead with Dr. Varun Bhasin. Varun did his residency at Stony Brook University Hospital and subsequently is now in the third year and almost the last leg of his fellowship program here at Robert Wood Johnson, and then has aspirations to get into imaging and has been absorbed into the pipeline of advanced imaging fellowship at University of Pennsylvania. And now I'll invite Varun to come over and give his take on one of the clinical trials.
Thank you for the introduction. I'm just going to start sharing my screen. Okay. And you all can see my screen, correct?
Yes.
Okay. All right. So I'm going to briefly highlight the statins to prevent cardiotoxicity from anthracyclines, or the STOP-CA trial. Now, this was presented as a late-breaking clinical trial by Dr. Thomas Nealon during the ACC conference. So to start with some background, of course, anthracycline chemotherapy is widely used in a variety of cancers, including breast cancer, lymphoma, leukemia, and sarcoma, and is known to increase the risk of heart failure up to 10 to 15 times in certain populations. The cardiotoxic effects of anthracyclines are dose-dependent, and cumulative anthracycline exposure has been shown to be a consistent risk factor for cardiotoxicity. Now, there's limited existing literature that's shown decreased anthracycline-associated LV dysfunction or a lower rate of heart failure with statin therapy. Now, that includes retrospective studies and a small randomized trial of approximately 40 patients, so limited data. And then more recently, a multi-centered randomized trial comparing atorvastatin versus placebo in patients with breast cancer and patients with lymphoma did not show a significant difference in the decline in ejection fraction between study groups. So that was a negative study. Therefore, there's definitely room for further investigation looking at the role of statins in this patient population. That's where the STOP-CA trial comes in. So the objective was to investigate the effect of atorvastatin compared to placebo on the occurrence of cardiac dysfunction among patients with lymphoma being treated with anthracyclines. So this study enrolled patients diagnosed with lymphoma, either non-Hodgkin's or Hodgkin's. They were adult patients over 18 years of age or older, and they were scheduled to receive anthracycline chemotherapy. Now, you might ask, why is this a suitable population? Well, lymphoma is a common cancer with a high survival rate, and the impact of late toxicities is important. Also, there's a higher rate of cardiac dysfunction and clinical heart failure from the literature compared to breast cancer. Now, for our exclusion criteria, the trial excluded patients who already had an indication for statins, or patients who were already being treated with statins, and patients who could not undergo cardiac MRI due to a contraindication, and those also who were getting cyclosporin. So now I will briefly touch on the study design. This is a multi-center randomized double-blinded placebo-controlled trial. It was conducted in USA and Canada at 9 different centers, and 300 patients were assigned to this trial. And the median age was 52 years and about 47% females. And the median dose of anthracyclines used was 300 milligrams per meter squared. So among 300 patients, 150 were allocated to the atorvastatin group and 150 to the placebo versus and control group. And these patients were assessed at 12 months of follow-up, and about 95% of patients completed the study. So to further outline the process of the study, prior to randomization, patients underwent echo, cardiac MRI, and baseline labs. And then they were randomized to each group. And then they underwent their first chemotherapy infusion, and then they underwent safety labs at 1 month, 3 months, 6 months. And then finally at 12 months, they underwent repeat follow-up imaging with echocardiography, cardiac MRI, and then again labs. So for our study endpoints, our primary endpoint was the proportion of patients who had a decline in their ejection fraction of greater than 10 or equal to 10% to an EF of less than 55%. The secondary endpoint was a proportion who had a decline in their EF of greater than or equal to 5% to an EF less than 55%. And some of the key exploratory outcomes were an absolute reduction in the ejection fraction by group and pre-specified subgroup analysis based on absolute ejection fraction change. They also looked at rates of incident heart failure. And in terms of safety outcomes, there were some key adverse events that were of special interest. So for our primary endpoint, the incidence was only 9% in the atorvastatin group at 12 months versus a 22% incidence in the placebo group. And this is illustrated here in our figure on the right. So there was clearly a very significant result there. Another way to look at this, in the placebo group, the odds ratio was 2.9 of achieving the primary endpoint, which is almost 3 times greater odds of reaching the primary endpoint. And then for a secondary endpoint, 21% had a decline in their EF of greater than or equal to 5% compared to the baseline to that EF of less than 55%. And the incidence of the secondary endpoint was 13% in the Lipitor group and 29% in the placebo group. So our exploratory subgroup analysis really aimed to look at who would benefit most from atorvastatin. And they found that females and patients with an age of greater than 52 years and those with receiving an anthracycline dose of greater than or equal to 250 milligrams per meter squared were some of the groups that benefited most. Also, obese patients benefited from atorvastatin. So I think it's important to highlight that higher dose of anthracyclines, those are the patients that are really benefiting. Additionally, for side effects, I think it's important to highlight that there was no significant difference between the study group and the control group when it came to the following adverse events, including muscle pain, transaminitis, myositis, and renal failure, indicating that the drug is relatively well tolerated in this population. And then I'd like to look at some of the study strengths and then discuss some of the study's limitations. So this is a strong study because it enrolled multiple sites in the USA and Canada and has a highly relevant study population and had 100% enrollment. Follow-up was available in 95% and drug adherence was high at greater than 90%. Now to kind of move over to limitations. Now this patient population was only patients with lymphoma. The sample size was about 300 patients, so modest size. And we looked particularly at the LV ejection fraction in the study, and it was assessed at 12 months. But after 12 months, it's not clear if the benefit would have been present. So it's really at 12 months. So longer follow-up is needed. Also, the study was not powered to really test an effect of atorvastatin on clinical heart failure. And the primary endpoint looked particularly at EF. Finally, this study didn't enroll a racially or ethnically diverse population, although women and men were well represented. There was nearly 50% women. So in conclusion, the STOP-CA trial demonstrated that patients getting high-dose anthracycline therapy for lymphoma were significantly less likely to develop LV dysfunction after taking Lipitor for 12 months. And now this trial supports the use of atorvastatin in patients with lymphoma who are at high risk for developing LV dysfunction on anthracycline therapy. So this trial set the stage for future study, and there's definitely a lot of room for future study. We need to determine which subgroups would benefit most from statin therapy, and also the optimal timing and duration of statin therapy during treatment. And another question that needs to be answered is, does this benefit that we saw in this trial extend to other patients with other types of cancers? So it's an exciting time to be looking at this topic. And these are my references. Thank you.
Thank you, Varun. Very important study. I think just highlights that statin is never a surprise and it keeps on extending its benefit in different populations. But we'll get to some discussion later on. But now I'm going to invite Dr. David Allen Lindsay. David came from Temple University and is now also in the last year of the Cardiovascular Fellowship Program, and subsequently is going to follow up with an imaging fellowship in Columbia University. So David is going to present a trial.
Thank you, Dr. Sengupta. You just share my screen here. Okay, guys. So I'm going to present some highlights from the CLEAR Outcomes trial, and particularly investigated bempedoic acid and the cardiovascular outcomes in statin-intolerant patients. So, just to give you guys some background, bempedoic acid had been revealed to cause reduced levels of LDL cholesterol in about 17 to 28% of patients. 17 to 28% reduction in LDL cholesterol with patients. In 2020, they found this out. And it was promoted and approved by the FDA and the European counterpart for use for this indication. However, they hadn't done any randomized trials or control trials to examine the effects of bempedoic acid, long term. So in 2016, they started a phase 3 global cardiovascular outcomes trial for bempedoic acid. It was launched with more than 14,000 patients in 32 countries, and it concluded in 2022. And we were lucky enough to see the results of this trial presented at ACC this year. So what is bempedoic acid? Just a quick review. It is a ATP citric lyase inhibitor, and it targets the ACL enzyme, which is responsible, a reductase enzyme, which is responsible for a statin metabolism pathway. What it does is it acts about 2 steps upstream from the statins, which inhibit HMG co-reductase. And it's a prodrug, which is activated in the liver. And what it does is that it causes an upregulation of the LDL receptor, and thus a decrease in LDL-C in the bloodstream. So same effect as statins, but what we've found is that there is a decreased effect in skeletal muscle. So the drug itself, bempedoic acid, is not, it's actually exclusively activated in the liver, thereby, reducing some of the side effects that we see with statins, statin-induced myopathies, because skeletal muscle also has it can also be activated in skeletal muscle, statins. So the study was a very, very big study, and it took place over 2016 to 2019. It is a double-blind, randomized, placebo-controlled trial. Involved about 1,250 sites in over 32 countries. And it's essentially the inclusion criteria: patients 18 to 85 years old of age were eligible if they met 2 criteria for increased cardiovascular risk: a previous cardiovascular event, so-called secondary prevention patients, or clinical event, or clinical features that place them at high risk for cardiovascular events, so primary prevention patients. So eligible patients had to report being unable or unwilling to receive statins owing to the adverse effects that had started for increased during the statin therapy and resolved or improved after statin therapy was discontinued. So the so-called statin intolerant patients. So what happened is that once they were selected, these eligible patients entered a 4-week run-in period with the placebo. If they adhered to therapy or didn't have any side effects, they were randomized in the 1-to-1 ratio to receive either bempedoic acid or at 180 milligrams or a matching placebo. And they followed these patients and added them to the study between 2016 to 2019, about 13,970. It was a highly powered study, about 90% power. It was aiming for to get a result of at least 15% relative risk reduction at the primary prevention endpoint. So the patients were followed for a median of about 40.6 months, not a long time, actually. So the primary endpoint was a 4-component composite endpoint of major adverse cardiovascular events, defined as a death from cardiovascular causes, a non-fatal myocardial infarction, non-fatal stroke, or coronary revascularization, as assessed by in a time to first event analysis. And then there were some key secondary endpoints also as assessed in a time to first event analysis. And they did it in a hierarchical order. They had a 3 composite endpoint from death for cardiovascular causes, non-fatal stroke or non-fatal myocardial infarction, and so on and so forth, as you guys can see on the slide here. So some of the initial results that we've seen looking at LDL cholesterol levels within the first 6 months, they saw for bempedoic acid a 21.7% reduction from baseline. So the time average reduction in LDL cholesterol of at least 22.0 milligrams per deciliter over the duration of the trial would be expected to lead to an approximate relative risk reduction of cardiovascular events. And The difference in percentage reduction was about 15.9% in favor of bempedoic acid compared to the placebo. Then they also looked at high sensitivity CRP levels, which is a marker of inflammation in these patients. And they've shown that at 6 months, there's a difference in percent change in the medium high sensitivity CRP level. It's about minus 21.6 percentage points in favor of bempedoic acid. So looking at the big primary endpoint, which is a 4 composite endpoint for MACE, they saw a significant reduction in the cumulative incidence of events. This was a hazard ratio of 0.87. And this was seen over an average of 40.6 months, as I told you guys. Then they looked at some of the secondary endpoints, so 3 composite MACE, which is also significant with p-value of 0.006. And then they teased it out into some individual endpoints. Fatal or non-fatal MIs, and there were less cumulative incidence for those patients taking bempedoic acid compared to the placebo. And then they looked at coronary revascularization events, and it was significantly less also for the bempedoic acid patients. Now, they looked further at other endpoints as listed in the prior slide, and what they found is that there was no significant difference between bempedoic acid and placebo. So just in summary, they're asking about what are the adverse effects of this drug? You know, they teased it out over the course of 40.6 months. And what they've found is that largely there are similar side effects for the bempedoic acid and the placebo. However, they did see a reduction in the renal tubular excretion of uric acid and creatinine that was observed for the bempedoic acid group, which leads, said a lot of patients develop gout, actually. So there was also incidence of elevated hepatic enzyme levels and gout, of course. They were higher in the bempedoic acid group. And there was also a higher incidence of cholelithiasis, which is higher in the bempedoic acid group compared with the placebo. So the drug is not without its, adverse side effects, and it has to be monitored pretty closely. So there's some limitations of this study, even though it had some powerful results. Largely, the racial makeup was Caucasian, about 90%. About 20% of patients that were screened were of Hispanic heritage. And if you look in the supplemental, there was very little patients of African-American heritage that were added to the study. So the duration of the trial was too short. None of these LDL cholesterol-lowering non-statin therapies, including bempedoic acid, reduced the risk of death from cardiovascular causes, which may reflect the effectiveness of contemporary adjunctive therapies. They need, a longer treatment duration to reduce the risk. So there's any lack of these drugs on mortality. So the inclusion of patients who had reported that they were unable or unwilling to take statins, a factor that may have resulted in high mean LDL cholesterol at baseline. So these are patients that they teased out, particularly saying, okay, I can't take statins. It turns out that these patients' LDL were even higher at baseline. So the effects of bempedoic acid and cardiovascular events in populations with lower LDL cholesterol wasn't really looked at. And, it's controversial. So we have to look at all patient sets and see if they also would benefit from it. So these were some limitations of the study. So in conclusion, among patients for whom primary or secondary prevention of cardiovascular disease is clinically indicated, but who are unable or unwilling to take guideline recommended doses of statins, the risk of the primary endpoint was significantly lower by 13% with bempedoic acid than it was with placebo for minimum 40.6 months. So the time average reduction in LDL level of about 22 milligrams per deciliter over the duration of the trial would be expected to lead to approximately a relative risk reduction for cardiovascular events. And they said they observed lower incidence of cardiovascular events, suggest that bempedoic acid is among the medications that lower the LDL cholesterol level and have a clinical meaningful cardiovascular benefit for these patients. And the key difference in bempedoic acids is bempedoic acid's pharmacology, given that it's a prodrug which is exclusively activated in the liver, thus negating any incidence of muscle-related myopathies as seen with statins. Thank you.
Thank you very much, David. I'm just looking at the clock, and I think I want to have a little bit of discussions, but wanted to, if you want to share the slide, I will quickly try to present the late-breaking study that we had an opportunity for those who had seen this. This may be a repetition, but those who have not, maybe I'll quickly go over what the findings are because this is relevant. We are going to continue the study. This particular study was focusing on the bloodless estimation of troponin and is based on the fact that troponin consumes to be one of the largest test order for chest pain in the emergency room. And the whole philosophy of measuring it using infrared ray spectrophotometry is basically devised on a concept of attenuated total reflectance. So if you have the infrared rays passing through a crystal, it gets completely reflected. But just at the interface of the skin and the crystal, there is an exchange of energy that happens, a photonic exchange, and that alters the spectrum of the returning infrared waves, and it can be decomposed for the molecule of interest. In this particular instance, we were interested in looking at troponin, high sensitivity troponin-I. And this has been there for a long period of time, but the form factor of the existing equipment is very large, and that has been compressed into a wearable device. And there is no wearable device currently in the market for estimation of troponin-I. And there have been preliminary studies that we had done that had looked into the efficacy in multiple steps. And that led to this particular study where we were wanting to see the feasibility of deriving this value in a clinical setting and performing a head-to-head comparison with a lab estimated high sensitivity cardiac troponin-I. And it was basically 5 site studies, and in 3 sites the data was collected with parallel blood draw and a machine learning model that was trained. And subsequently in 2 sites the validation was performed on unknown unseen patients, and also there was a correlation with the echocardiographic and the angiographic profile of the disease in MI was seen. And it is being done in the cardiac cath lab here. And if you would have seen this device, it's pretty simple to be applied. We have our coordinators who do this routinely. You have to have a good contact and strap the device, and then within 3 minutes you get a signal that will indicate whether the device is capturing correctly, and you'll get a value that is then reported. A machine learning model was trained to predict the presence or absence of elevated high sensitivity troponin-I. And we looked at the development and the validation cohorts. And finally, obviously, the data looked very promising in the machine learning model with a very high area under the curve for predicting elevated troponin-I, which was similar in both the internal and the external cohorts. And also there was a relationship between those observations with actual patient phenotype, presence of obstructive coronary artery disease, and echocardiographic presence of all motion abnormality. So this opens up a really great opportunity to do this bloodless estimation, and not just patients with MI, maybe in patients wherever any other form of biomarkers may be needed, be it BNP, be it any other biomarker. I think there's an ability for a spectrophotometric device to do that. There are several limitations. This was the first multi-center study, and subsequent studies are currently underway to look into the generalizability in populations beyond where this study was currently done. And I think what was very, and these are the different settings in which it will be utilized. It could be done in emergency rooms, and it could be done in pre-hospital settings, and maybe at home. So patient post-PCI, when they go home, one of the biggest concern is that they develop MI post-PCI and there is no blood sampling that is collected. So there's an opportunity to see for presence of myocardial injury in different settings. This was published in European Heart Journal Health, but more interestingly was a very, very impressive editorial, very complimentary. And I think I've never done my work where there has been a comparison made to E is equal to MC square. That's, I think, is the highlight of anything. But anyway, we were very pleased and overwhelmed by a very strong editorial. This work is going to continue here. We have already enrolled about 20 patients for now. But in the near future, I think if our community is desirous of extending it into other settings, I think we should be able to create many more such targeted discovery opportunities. All right, so with that, I think we come to the most interesting part of the discussion. And I wanted to just have at least one question posed to our presenters today. So I will start with Chris. Chris, you pointed out very elegantly that the curves were not separating after 2 years. So it seems like something that is happening initially is not conserved. Do you think it's because of additional comorbidities that might be reducing the gain because death, it was just an all-cause mortality? Was there some form of additional statistical analysis done to look just at cardiovascular death rather than just all-cause mortality?
Yeah, so I think there are some answers. It's hard to say, but I think there's some category of answers that would lead to just a chance or to artifact, and others that are real and substantive. So going for the artifactual is the fact that 2 years also happens to be the time where you start to get allowed per protocol crossover. So you could get misclassification bias that would attenuate any effect sizes. This is less likely because you still see an effect in hospitalization, but maybe it was just smaller and so it got obfuscated that way. But then on the other side, when you look in supplementary data, most of the events are still driven by heart failure specifically related outcomes. So I do think that the signal is real. I do think that at that time, the 2 year is probably cutting off and the gap is legitimately narrowing at that time. One possibility is that mitral regurgitation is this is more kind of abstraction, but perhaps it's that mitral regurgitation, secondary mitral regurgitation is the outcome of the underlying cardiomyopathy, and maybe it allows people to tolerate a certain degree of severity of mitral of LV dysfunction. But eventually that LV dysfunction just keeps going, and at perhaps 2 years, no matter how competent the mitral valve is, there comes a time when people still do worse, even though you kind of stop the dam for temporarily. That's at least how I'm thinking about it.
So, Chris, so just a follow-up quick question. So I don't remember, was there any follow-up echocardiography data 2 years presented to show that the effect that was achieved at 1 year immediately after implant was persisting? Because as you have correctly pointing out, the remodeling may be changing or the MR may be recurring. And so was there any ongoing differences in the pathophysiology? Was that ever presented? Do you know of?
Yeah, so this is from the supplementary data. It's hard to interpret right here because there's so much death that happens at 4 and 5 years. To give you an idea, this is from another graph in the supplement that shows black being the people who died. So take this with a grain of salt. But it does show that here device control, if you can see my mouse, device is the first column in the stacked bar plots. And we see that there are competent valves with 1+ or with 1+ MR in the device group that seems more so than the control group kind of throughout. The only place where this stops being relevant is the 4 and 5 year mark. They start to approximate, possibly because, at the 2 and 3 year mark, both groups start dying at just such high rates.
So that was not a planted question. That was Chris had this ready. So this is again credit to you, Chris, that you anticipated a question and had a slide ready. So congratulations for that anticipatory. You'll do very well on Young Investigator Awards if you ever apply. I never planted that question and you did it very well. Thank you. I want to go to next to Varun. No, I think we have Alberto. So Alberto, so tricuspid regurgitation, I always find it very difficult that they have this. No, this is a question I know that you are may not be completely versed with the echocardiography rotation, but it's surprising to me that tricuspid regurgitation should have so many other grades beyond severe of massive and torrential. Do you think this is just something that is artificial? Because what if even if you have a reduction and it still continues to be severe, maybe it will not make any difference. You know what I'm saying? Once you are severe, it doesn't matter how severe you are. Any thoughts on that?
That's a good question. I know that they did, when they classified patients, they used severe, massive, or torrential. But I still think when they looked at data was, just seeing a reduction in severity by a couple grades. So I don't think when they looked into it, they would classify it going from torrential to severe as an improvement. So I'm not sure if there's much clinical difference if someone has severe versus massive or torrential TR in terms of how they do with or without this procedure.
So the reason being, there's a significant degree of skepticism, at least we have. There are 2 or 3 schools of thoughts that once it's severe, it doesn't matter if it's massive or torrential, it may be severe, it doesn't matter. I mean, it's easy to showcase that you reduced to some grading, but you really didn't do a perfect job. So again, open to further clinical studies where they will do a complete tricuspid valve replacement, and maybe there is a better result there. We'll look forward to seeing that. All right, so Varun, again, an interesting study with statins. Now, I wanted to ask you about, I think this could be speculative. What is the speculative reasoning or the mechanism? Is this the pleiotropic antioxidant effect because anthracycline have create oxidative stress? What was the discussion about that?
Yeah, so I think the main thing is like you just alluded to is that they can reduce. There's free radical entry that often causes cardiotoxicity, and when it comes to anthracycline therapy, and I think that what we can speculate potentially is that this is just another benefit of atorvastatins, like you mentioned, the pleiotropic effects, that perhaps there is some reduction in the free radical injury that is occurring, and then eventually going down that pathway where you see a decrease in the ejection fraction. So I think statins are quite amazing, and this may be a possible mechanism, but we don't know for sure at this point. It needs further study.
Great. And then finally, David, I think you may have mentioned, I might have missed it, but I wanted to ask you. So if someone is not able to achieve a goal endpoint with statin alone, or has started developing some side effect, could you just maybe think about a combination? What do you think? Is that a possibility? Just like instead of using ezetimibe, you use statin plus bempedoic acid?
Yeah, I mean, if you look at the drug distributor's website, it's pretty eloquent how they present it. Just because you're going to start someone on bempedoic acid, there are certain patient subsets that can tolerate statin. They just don't see a reduction. So what we do is we add bempedoic acid to that regimen, and the cumulative effect of the statin and bempedoic acid, sometimes with addition of ezetimibe, actually causes a reduction in the LDL cholesterol, significantly so. So yeah, I mean, at some point they may make these combo pills, that may do very well for patients in the long run. So, but yeah, they haven't studied that patient population, as I said earlier, where the LDL is not necessarily high, but it's on the lower end, but not necessarily where they want it yet. So it was only the statin intolerant patients with conceivably they had very high LDLs to begin with. So
yeah, so I think that may be a important consideration, and it's interesting. At least we have an additional sets of not so expensive. I don't know what the cost is, but maybe it's not as expensive as PCSK9 inhibitors. So more to come on that direction.
Yeah.
Great. So I think I want to thank all the panelists. You guys did an excellent job. There was one question. So Dr. Ashok Chaudhary is also congratulating all of you. I want to just have a quick shout out from you. What was your what was the overall feeling at the ACC? I think Varun, what did you think about overall for your academic career?
I think these conferences are always a wonderful experience. I always enjoy seeing the late-breaking clinical trials and, you know, just the spirit of academia that brings everyone together and things like Jeopardy. So it's such a fabulous experience for fellows, especially like us in training, to see, you know, people come together and share their work. And I had a great time, you know. The whole fellowship came together, I think, and unified over, you know, ACC this a few weeks ago. So it was a lot of fun.
Alberto, your high points.
Yeah, and just piggybacking off Varun, I think it was a great time. I really learned a lot. Some of the sessions, the academic sessions, were really insightful. You know, learning about topics that, you know, we haven't really gone over too much here, and the late breaking trials, and having the panel there where, you know, they take apart the studies and everything was really interesting to go to, and being with everybody as well.
Chris, I know that you were in between night shifts and I think you barely made it. What was your high point?
Yeah, I mean, though I came straight from night float, it was a really invigorating time, and like everyone said, very educational. I got to attend some global health sessions too, which I don't usually get to explore. And that was really reinvigorating to be able to visit that interest.
And David made it despite all the odds, despite losing the hotel booking, and you were able to find a room, and the spirit was still alive.
Yes, it was wonderful. It was wonderful. I think at the end of the day, I underscore everything everyone says, but it was, you get to see just how much there is still out there for you to learn that you just haven't, you know, grasped yet, you know, and there's so many minds there, you know, you're sitting next to somebody picking a conversation, you'd be surprised just what you can learn and what they can learn from you as well. So I think it was a fabulous experience. I can't wait for Atlanta next year. So
absolutely. And with that note, I'd like to just invite each of our faculty members who are joining today from wherever you are, part of the faculty or the community cardiology fraternity and the entire cardiology fraternity and fellowship, get prepared for the next ACC. We want to make it again happen in a big way. Thank you, everyone. Have a good night.